Hi, I'm Dr. Rahi Victory. I'm a reproductive endocrinology and infertility specialist, and I'm very pleased to have the opportunity to speak with you today about unexplained infertility, a topic that's very near and dear to me. I'd like to thank the organizing committee of the Canadian Fertility Show for giving me the opportunity to speak with you all today. I don't have any financial interests in any products or services in this presentation. I do own a IVF laboratory, and that would be probably my only interest in this. I do believe in a very scientific approach to infertility, and I don't believe people should spend any more money than they need to. And most importantly for me, I don't believe in a cookie cutter approach to infertility, so I don't believe everything is IVF. So the objectives are to define unexplained infertility, to understand the epidemiology of the topic, understand what testing should be done, understand what treatments are effective and which ones are not, and to look at the frontiers and areas for further research. So we're going to go over all of these in detail, and I hope you'll follow with me on this interesting journey. So what is unexplained infertility? The reality is it's hard to get agreement on a definition. Some reproductive endocrinologists believe there is no such thing as unexplained infertility, just insufficient testing. So based on old definitions, and this is going back to 2017, which is really not that old, it's simply called the absence of identifiable causes. Well, that's a bit simplistic because it's hard to understand what the causes are without knowing what can actually cause infertility. So we need to understand infertility first before we can really understand unexplained infertility. So let's have a look at what infertility really is. So Fertility 101, or Fertility for Dummies, about 40% of the time you're going to find it's male factor, and that is related to sperm counts, motility, progression, morphology. More and more we're looking at the DNA fragmentation, antibodies to sperm, oxidative damage, and the potential for infections. About 40% of the time we'll find a female factor. Are you making an egg would be the first question. Are the sperm and the egg meeting, and is the pelvic environment normal? Is there endometriosis? Are there adhesions? Is there scarring? Are you producing good quality eggs, which is obviously one of the most important factors that we deal with? And then are we missing something which is in the pelvis or in the bloodstream that we don't know about because our basic testing doesn't demonstrate all of that? And then about 20% of the time, we find out that there are two factors involved, one male and one female. So what kinds of things are we not testing for? Well, that's important as well because we need to know what we're missing in order to figure out if it's part of our unexplained infertility. And this is a very interesting topic now because every day people find something new. So I call this answering the WTF on unexplained infertility, or more importantly, rise of the expensive tests. As you can see, there's a long list of things that people have been trying and exploring and determining if these are valuable or not valuable in the determination of infertility and unexplained infertility as well. So there are many things. So the definition of unexplained infertility really hasn't been fully defined. At the present moment, it's basically after you've excluded every possibility you can explore and can't find an answer. And that's as simple as it is. We don't have general agreement on what is really the definition of unexplained infertility. But let's take a look at the epidemiology of at least what we think is unexplained infertility. So about 25 to 30% of couples will have unexplained infertility. Some degree of age dependence does occur. So if you look at the slide, you can see here in the bars that from 20 to 29 in the unexplained category, which is the unspecified origin, this red bar, about 27 per 10,000 patient years. When you get to the 30 to 39, it almost doubles to 59.8%. And when you get into the higher age group, you're looking at a 31% rate. So there's a little bit of a bell-shaped curve there where age does have a significant effect. But in terms of racial backgrounds, you'll find that it's relatively constant between the various groups. There is some fluctuation, but overall you're looking at 32.5, 42, 32, 35, and again 32. So racially it's not particularly different. Everyone seems to be at the same risk, but age does seem to play a role. What kind of tests do we do? Well, there's the basics: hormones to confirm ovulation, confirmation of tubal patency, and a semen analysis, whether you're looking at basic or advanced. More advanced testing: FSH, LH, your thyroid, which is your TSH. Some of us will do thyroid antibodies, and a prolactin level, your anti-Müllerian hormone level, which is more and more gaining favor in terms of determining if the ovarian reserve is strong enough or not. Vitamin D levels, some of us will measure, we do in our practice, because it has been shown to be very important for both getting pregnant and staying pregnant. And more we're seeing sperm DNA fragmentation on the horizon, where it's taking a more prevalent role in determining the fertility potential of couples and whether or not the male factor could potentially lead to a miscarriage or failure. So let's assume that you've determined from testing that you have unexplained infertility, and you want to know, what are my chances if I don't do anything? What if I don't try any of these fancy treatments? What if I don't want to get involved in IUI or IVF or any of the other things that we do as fertility specialists? Well, you can see very clearly that in 1998, Guzik et al. Said there's a 1.5 to 4% chance per month that those couples will be able to conceive on their own. In a very good study done in 2017 by Van Ekelen, 38 centers in the Netherlands with almost 5,000 patients, they show here in this graph very clearly that at 1 year from the time that they had their testing, about 27% were pregnant, 33% by 1.5 years, 38% at 2 years, and 41% at 2.5 years. So your cumulative pregnancy rate continued to rise and increase over time, even with no intervention whatsoever, as long as you kept trying on a regular basis. So can patients with unexplained infertility get pregnant from expectant management? Absolutely they can. With no intervention from us, it's very possible that some of these patients will conceive on their own and go on to have live births. And so this is a very reasonable approach for some patients who either for personal reasons or financial reasons don't want to get involved in doing a full-on fertility treatment. Now, it's important to note that while the probability over time does increase, your overall chances are diminishing compared to where they were at the beginning. Now, I know it's a bit of a confusing concept, but the reality is month to month, the probability is going down. The percentage goes up, but the actual chance that it's going to occur is going down. So there's a difference between the absolute rate and the actual chances that it's going to occur. So in couple A, you have a 30-year-old, she's never been pregnant, she's been trying for 1 year. In this particular study, they estimated that you're going to start off with about a 30% probability of conception within 6 months of trying, but you can see that it starts to dwindle down over time. In the other couple, in couple B, they're 40 years old, she's been pregnant and had a child before, but they've now been trying for 2 years. So she's starting out at somewhere around a 15% success rate, and it's dwindling down to below 10% quite quickly over time because age is now playing a very significant role. So you need to factor in that while your overall cumulative percentage may increase over time, the actual probability overall is decreasing because of age and failures in previous cycles. So this is important for patients to factor into their calculus when they're deciding what to do. So what are the medical options of treatment for unexplained infertility? Well, there's clomiphene with intercourse, there's letrozole with intercourse, there's injectable medications with intercourse and a combination of the oral with the injectable. There's IUI alone. There's oral medications in IUI, injectable medications in IUI, and then there's IVF. So let's have a look at each of those in detail. And as we go through it, I'm going to show you what the recommendations are from either CFAS or ASRM, the two big societies in Canada and America that guide fertility doctors in terms of their treatment and post all the guidelines that we use to help our patients. Well, let's look at clomiphene with intercourse. So clomiphene citrate is an oral selective estrogen receptor modulator. It's the original therapy for PCOS treatment, and it basically tricks your brain into thinking that you don't have enough estrogen, so you're going to secrete more FSH and LH, which causes the release of one or maybe more follicles. And they've got 4 randomized controlled trials and 3 systematic reviews of the RCTs, which compared clomiphene citrate with just simple intercourse. There is absolutely no difference in any of the outcomes. So clomiphene alone with timed intercourse is not of any value when you are trying to get pregnant and you have unexplained fertility. So the summary, there is good evidence that clomiphene citrate with timed intercourse is no more effective than expectant management. It is not recommended to use Clomid with timed intercourse as a treatment for unexplained infertility, as it is no more effective than expectant management. And that's a level B recommendation with moderate evidence. So this is really important because we get a lot of patients that show up who have taken Clomid either from another physician or even some fertility centers, and it's useless. It's not doing anything. You're actually wasting time. So don't take Clomid. What about letrozole? Letrozole is an aromatase inhibitor. It reduces estrogen levels, which again makes the brain think you don't have enough, so you send out more FSH, hopefully makes the follicle grow and release and mature. And it's primarily used for breast cancer, but a previous colleague of mine, Mohammed Mitwali, and the amazing Bob Casper realized that it can be used for fertility as well. It's currently the first-line therapy for patients with PCOS. So there are 2 randomized controlled trials and 2 systematic reviews of the randomized controlled trials. And again, they showed no difference. So 11.1% versus 7%, which is not of any value. So in these trials, we're not seeing a difference. So based on these findings, there is good evidence, again, that letrozole with timed intercourse is not of any value. It's not more effective than Clomid and timed intercourse. It's not more effective than expectant management. And so the recommendation is that it not be offered as an option for patients who are just using it with timed intercourse. And the strength of that evidence is a B, and it's a moderate strength of recommendation. So that's an important factor because, again, we get a lot of patients that show up who have previously been given letrozole instead of Clomid, and this is not going to help you. It's of no benefit for patients that are trying. What about doing injectable medications with timed intercourse? So obviously many of you have heard of injectable medications. There are many available on the market, and it's kind of the holy grail of fertility treatment because everyone's worried about having to jab themselves with the needle. So these are either injectable FSH or LH, and we now have some drugs that have the combination of both in one pen. It basically stimulates your natural production of those hormones, but is giving you more than you would produce on your own. The benefit of this is that it can help you genuinely produce multiple follicles. And so you're hoping that with more targets to hit, your sperm is going to have a better chance of getting to one of these eggs, forming an embryo, and that embryo will have a better chance of implantation. Now, there aren't any direct comparisons to expectant management for injectable medications alone. But when they compared it between injectables or just IUI, so you were either just doing injectables or just doing IUI, there was no difference. There was no difference between just injectables and oral medications, which is interesting because the injectables are stronger. And there's a significantly higher risk of multiples ranging from 6.5 to 22%. So this is very significant because one of the things we have to examine are the risks of the procedures, and having multiple babies is a risk. So ASRM summarized this by saying there is insufficient evidence that gonadotropins, which are those injectable meds with timed intercourse, is superior. There's moderate evidence that treatment outcomes with gonadotropins are similar to the oral medications in timed intercourse cycles, but much higher rates of multiple gestation. And so the recommendation, it is not recommended to use the gonadotropins with timed intercourse. Again, the strength of evidence is level B, and the strength of the recommendation is moderate. So once again, these are very important because there are places where they will try and give you the shots alone, and people say, I don't want to do the insemination for whatever reason. You're actually wasting your money on those drugs because the drugs alone are not actually going to prove to be beneficial. They're actually going to be wasting your time and your money. And there are side effects, including having multiple gestations if you are successful. So this can be a risk without any significant benefit for you. So we've tried the oral meds, we've tried the injectable meds, they're not working. What about just doing insemination for those who feel that this may be of benefit to them? You can see in the image there, basically the process of insemination is simple. We prep the sperm through a sperm wash technique. There are various ways that this can be done. You then inject the sperm into the uterus with the hopes that the sperm are getting to the fallopian tube, finding an egg and fertilizing. This is important because under normal circumstances where you're just having intercourse, only about 200 sperm eventually make it to the egg. But with insemination, we can literally pour millions of sperm in there. So you're just hoping to overwhelm the eggs and get as many sperm there as possible. So when they looked at this, there are 7 randomized controlled trials, 1 cost effectiveness study, 6 cohort studies. Batacaria is probably the most famous study. It's a study done in Scotland. And when they compared doing IUI alone versus doing no management, just expectant management, it was 23% for the IUI group and 17% for the management group, with a 6-month interval of trying, and so that was not statistically significant. So there is actually no difference between those two. And they did a cost effectiveness study which showed that it was not of any benefit. So based on this and the other studies, strong evidence that intrauterine insemination in unstimulated cycles, meaning natural cycles, is less effective than stimulation with insemination, and I'll show you that in a moment, and it is not significantly more effective than just trying on your own. So it is not recommended to perform IUI in natural cycles for the treatment of unexplained infertility. It's actually less effective than trying oral or injectable meds with IUI, and it's no more effective than trying on your own. This is level A, strength of evidence, and a strong recommendation. Okay, so finally, some good news. Oral medications and IUI may work. So we know oral alone doesn't work. We know that the IUI alone doesn't work, but what if we combine the two? So essentially what you do is you take your Clomid or your letrozole, you wait until your ovary is ready to release the egg. Some people will trigger, some people will not. And then you go ahead and do your insemination. So there are 19 randomized controlled trials for Clomid, 4 systematic reviews of the RCTs, and 3 cohort studies. This definitely works. You get a 24% live birth versus 7% within 3 cycles. So that's very significant. You're over triple the opportunity. And so this does actually work. You see basically the same thing with letrozole, multiple studies, 8 randomized controlled trials, 2 systematic reviews, and they showed a 240% increase compared to just trying expectantly. So the combination of the oral meds with insemination does positively impact your success rates and gives you a much better chance of success compared to normal. So many of you will have jumped online, read various reviews or posts. Lord knows Dr. Google is everywhere. So is Clomid better than letrozole when you're using IUI? And the answer is no. There are no differences in head-to-head comparisons. The live birth rate is the same, the miscarriage rates are the same, and the multiple gestation rates are the same. So no matter what you're reading online, there is no difference. You can choose to use Clomid and IUI, or you can choose to use letrozole and IUI. It doesn't make a difference for unexplained infertility. So the summary here is there is strong evidence that clomiphene citrate with IUI is superior to expectant management and natural cycle IUI for the outcome of live birth rate in couples with unexplained infertility. The recommendation is that it is good to use Clomid with IUI. This is strength of evidence level A, and it is a strong recommendation. There is also strong evidence that there is no significant difference in pregnancy rates or multiple gestation rates following letrozole with IUI compared to Clomid with IUI. Both are superior to expectant management or just natural cycle IUI. And so again, the recommendation is letrozole and IUI is a reasonable option, and it can be considered as an alternative option. And they do note, at least in America, that it is not used or FDA certified for fertility, but everyone knows that it works and it's widespread use. This is a strength of evidence level A, and again, a strong recommendation. So what happens if you do a little bit of mix and match? What if we take the oral meds and some injectable meds so that you're not spending quite as much on the injections, because we know it does decrease the amount that you need, and we add in the IUI. So we're doing kind of a hybrid program here. And I call this, if at first you succeed, let's try to keep getting better. So there are 6 randomized controlled trials and 6 cohort studies. They demonstrated no significant difference between Clomid and IUI, which gave you an 8.3% success rate, low dose FSH or the injectable and IUI, which was 12.1%, and Clomid and the FSH and IUI, which was 13.6%. Now in the cohort studies, they did show a small benefit to mixing, but they had a 16% multiple pregnancy rate, which is very high, including 2 sets of triplets, and 3.7% of the patients developed ovarian hyperstimulation syndrome, which can be a risky condition requiring hospitalization and placing you at risk of problems with renal failure, liver inflammation, blood clotting, and really being quite ill. So this is something we desperately try to avoid these days and want to avoid at all costs. So based on the fact that the cohort study did show an improvement, they said that there is fair evidence that clomiphene citrate and conventional dose gonadotropins with IUI all combined together, so these are your pills, your shots, and your IUI, may give you a higher pregnancy rate than just purely expectant management. Not a shocker, we already know the pills with IUI do. Why wouldn't the pills with the shots and the IUI help? But they don't recommend it because they say that most studies that did demonstrate a benefit showed a much higher rate of multiple pregnancy and also demonstrated an increased risk of OHSS. This is a strength of evidence B and a moderate recommendation for the strength of the recommendation. What about injectables and IUI? So what if we get something stronger like the injectable medications and combine it with the IUI without introducing the oral medications at all? So there's 2 kind of branches to this. There's a low dose approach, which is 75 to 150 units, and then there's what they call the conventional dosing, which is over 150 units. And these days, very, very few doctors will use over 150 units when trying IUI because we're also concerned that we don't want to end up with multiple pregnancies. So in the low dose, there are 13 randomized controlled trials, 1 systematic review of the RCTs, and 1 cohort study, and they showed no difference when they compared it to expectant management. So using low dose shots with IUI is not better than just trying on your own. Interesting, because I was expecting a benefit, but it doesn't show that. And there is a substantial increase in cost, which is why Kim Kardashian is flipping dollars at everybody. When you get up to the conventional dose where you're using over 150 units a day, there's 8 randomized controlled trials and 2 cohort studies. There are no studies that actually directly compare conventional dose with expectant management. It does appear to offer higher rates of live birth compared to oral meds and IUI. So this is important for everyone to consider. However, when you look at the summary, it says in gonadotropin IUI, you can get a higher gonadotropin dose being associated with a higher multiple pregnancy rate and a higher live birth rate. So they do say that it can be offered, and these are the Canadian Fertility Society guidelines. However, they do say that they want you to know that despite the fact you're getting a higher chance with this, you are getting a much higher multiple pregnancy rate. Again, we're looking at those 16, 20% chances. You could end up with twins. Everybody thinks twins are wonderful and cute, but what we're really worried about with these high order multiples are triplets, quadruplets, and more. All of us have had them before. And even if it's just twins, it's an 80% divorce rate. So it's not something we take lightly, and all of us take this very seriously because there can be complications. Okay, so now we've arrived at IVF. Everybody wants to know about IVF because this is big business. This is what's being pushed by a lot of centers. Does it actually work? Well, yes. I mean, of course it actually works. So there are 12 randomized trials and 8 cohort studies. They're unfortunately all old. And this is really important as we go through this data, because in these older studies, they actually had very low success rates, 30, 35%. I would close down my shop if I was only getting a 30 or 35% live birth rate with my IVF program. So this is very, very critical to understand, because when we're comparing apples to apples, these are kind of rotten apples being compared to newer apples. And so it's hard to kind of place this in the right context in modern science and modern practice. So there's actually only one study comparing expectant management to IVF, and it was in patients that had been trying for more than 2 years. And there is a huge difference. It's almost a threefold difference, with a 38% live birth rate compared to a 13% live birth rate. When they looked at this based on age, they also demonstrated that if women are between 38 to 42, you're going to see a 15.7% chance in taking just Clomid and IUI, 13.5% if you're doing injectable medications and IUI, but a 31.4% success rate if you're going directly to IVF and skipping the insemination. So this is important because it's demonstrating that in patients that have had a long period of infertility, it looks like the IVF is definitely beneficial. In patients that have had age as a factor, it's also beneficial. But there are multiple studies which demonstrate that it's not that useful compared to just doing pills and insemination or shots and insemination if you're young and you're healthy and you're just unexplained. So if you're getting pressured to jump into an IVF cycle, don't feel that pressure is necessary, because it isn't. You may be perfectly fine and have a reasonable degree of luck trying just with oral meds and IUI, or injectable meds and IUI, or even expectant management. So this is an important slide. It's busy, but it's critical because this one can save you a lot of money. So hopefully you guys will follow along here. So the current evidence does not support using IVF as first-line therapy for unexplained infertility over expectant management, which is just you trying on your own for 6 months, or a limited course of oral stimulated meds with IUI in women that are less than 38 years of age. There is good evidence that immediate IVF in women over 38 years of age may be associated with a higher pregnancy rate and a shorter time to pregnancy as compared to a strategy consisting of either oral meds and IUI or gonadotropins and IUI prior to doing IVF. So you can go right ahead if you're over 38, you will get a better success rate. There is also good evidence that in couples who fail to achieve a pregnancy following oral stimulation and IUI, or even the injectable meds and IUI, that it's very reasonable to go straight to IVF rather than going to the injectables from the orals, because again, you will get a better chance. And for women over 40, again, this is a very reasonable consideration. There's also good evidence from these previous older studies, and here's where that older part comes in again, that ICSI is not beneficial compared to doing conventional IVF. Now, I'm going to contest this myself, because in our program, we have very, very high success rates with ICSI. And so we find that we get much better success when we are doing this. but we have unusually high ICSI success rates. In a program that has relatively normal or lower success rates with ICSI, you're really not going to see the benefit to it. So it's probably not as beneficial. So the recommendation, it is recommended that couples with unexplained infertility initially go 3 or 4 cycles of oral meds and IUI. For those who are unsuccessful with that approach, IVF is recommended rather than going to the injectables with IUI or the injectables and the oral meds with IUI. And the strength of this evidence is B, and the strength of the recommendation is moderate. Okay, so let's briefly talk about surgery, and I apologize if any of you are freaked out by any images here. The white object you can see there is the ovary. Up in the upper right corner, you're seeing the bottom left of the uterus, and those blackish kind of marks deep in the pelvis there are endometriosis lesions. So is surgery beneficial for patients with unexplained infertility? Well, surgery's fallen by the wayside because it interferes with getting people into medical treatments. And let's all be honest here, fertility centers don't make money if you're not doing fertility treatment. So it's become discouraged more and more. But the reality is there is a role for surgery, and the data actually supports it. And unfortunately, our Canadian guidelines say that it may be useful, but that they're not sure. But there's good data, and there's a 2022 article now from just in January, which goes through the benefits of this. So about 50 to 60% of unexplained infertility patients will have some type of lesion in their pelvis. There are multiple studies which support this. The majority of these lesions will be endometriosis, and some of them will have tubal adhesions in about 20% of cases, which can interfere with the function of your tubes. Unilateral or bilateral tubal occlusion, which means one side or both sides, can also be found in some cases, and again, there are multiple studies demonstrating this. The surgery has actually been found to be cost-effective in patients with unexplained infertility, which is important. And I'm going to freely admit my bias here. I am a huge fan of doing surgery because in the Endocan study, which is a Canadian study looking at doing laparoscopy and treatment versus no treatment of mild to moderate endometriosis, they had a huge difference, 30.7% success versus 17.7% success in the patients that were untreated. And here in Ontario, it's free. So why not undergo the surgery when it can be very beneficial? Now, are there risks? Of course there are. It's surgery, and that needs to be factored in. And Lord knows it takes a very, very long time to get into surgery these days. Even if your RE does surgery as I do, it takes a long, long time for us to get OR time. So there are risks and benefits to this choice. What's on the horizon? Well, hopefully you're remembering back to the slide I had with the fertility wars, like Star Wars. Genital microbiome assessment, this is very big right now. There are people that have disrupted or abnormal vaginal microbiomes or uterine microbiomes, and it does appear that there is more and more evidence mounting that this can play a role. Immunological testing, there are whole journals dedicated to this, and yet no one can agree on whether or not this is beneficial. And so I am becoming more and more of a believer for sure, but it's very controversial for, in the current literature. HLA haplotyping, the dreaded DQ alpha, no one knows if this is true or not. There are studies that show that it is detrimental in the extreme, and other studies that show that it had absolutely no impact whatsoever. Endometrial synchrony evaluation, things like the ERA test, this has now been proven to be useless. Don't waste your money. There are over 6 studies demonstrating that there's no benefit to doing an ERA. Seminal infection testing, so this is looking for infections in semen. This is brand new. We're just learning about it. No one knows if this has any benefit or impact whatsoever on treatment or outcomes. Sperm DNA fragmentation, as I mentioned to you earlier, looks like it's playing more and more of a role. And then there's that whole other section that we can't discuss today because of time, which are the naturopathic, traditional Chinese medicine approaches, homeopathy, acupuncture. Can those be beneficial? Okay, so conclusions ultra simplified. And I wanted to boil this all down for you in just 2 quick slides. So expectant management can often result in success, but it can take a long time. Oral medications alone are useless. So if you're being offered Clomid or letrozole alone, it's not going to help you. Don't bother. Shots alone are also useless. So don't do that if you're thinking you want to avoid IUI. You're not helping yourself. There are actually only 4 treatments that have been proven to be effective. Oral medications and IUI, injectable medications and IUI, IVF, and surgery. So if you're interested in any of those, you're going to see a concrete, tangible benefit. We've gone through the numbers, but if you don't want to do those, then there are really no good options for you other than trying on your own naturally. So if you need more information, make sure you reach out to www.cfas.ca or www.asrm.org. Please avoid Dr. Google. Google is a trap for medicine where you can easily find pitfalls and miss what's really important for you, or even sometimes be placed at risk. So these experts spend enormous amounts of time and energy trying to get guidelines out to you to help you. I would strongly encourage you to trust them. I'd like to thank the Canadian Fertility Show again for my presence here today and the opportunity to speak to you all. Take care.